Hi, my name is Zhong Zhong. I'm a beam scientist at the HEX, which stands for High Energy Engineering X-ray Beam Lab at the National NSLS-II. So today I'm going to talk about diffraction-enhanced imaging. So why bother doing it? So as you know, breast cancer is the most prevalent cancer. It's the second leading cause of cancer deaths, right after lung cancer in women. For this reason, so early diagnosis and treatment is key for survival. So lots of progress has been made since the 1990s, especially digital mammography. Despite that, early diagnosis of breast cancer is still a challenge. That's because of these fundamental reasons. Soft tissue has low X-ray contrast, and the mammogram you're looking at involves a complicated background. It's difficult to detect early stages of breast cancer. Also, breast is more sensitive to radiation compared to many other organs, such as my hand or my knee. So we invented a method we call it diffraction-enhanced imaging. That was 20 years ago. This method provides high contrast of soft tissue at a fraction of the current dose. So look at this phantom. It's called the American College of Radiology, ACR phantom. So we compare this phantom, the image with conventional X-rays and with our DEI method. So on the left, lower left, you see a map of the phantom. Basically, they have features that simulate lesions in a breast cancer. That's what radiologists look for. So you see the tumor mass, that's red dots. You see speculation, those are the green fibers. And you see the calcification. So this is called the phantom. It's used as a quality assurance for mammography. In a hospital, you do image this before the real patient every day. If you see three of these groups, three, let's say tumor mass, if you see 3 out of the 5, you pass, basically. So in the middle, lower middle image, you see a conventional X-ray of this phantom. It's for quality assurance, so they made it challenging. So you really don't see much. Yeah, you see 3 groups of each feature. Then on the lower right, you see the DEI image. That's our method. As you see, we see everything so clearly, including the manufacturing defects. So on the bottom of the image, you actually see the Scotch tape used to mount the phantom. So you do see everything. So I explain why we get such an amazing image. So here is a picture of what we do. So on the top is a conventional radiograph. Basically, you go to the hospital, be it mammography, CT, breast, chest X-ray. It's the same thing. You basically shine the X-ray through people, then the X-rays hit a detector. So you count on attenuation of X-rays to cast a shadow on the detector. That gives you the image. So on the bottom, we have our DEI setup. So same X-ray goes through the same people, but in addition, we have an analyzer crystal. This crystal converts small angular change in the X-rays to intensity change that's detected by the same detector. So that's the only change we made from the conventional X-ray. So here is one of the first images we took after we discovered DEI, again 20 years ago. So on the top row, you see nylon fibers of different diameter, the smallest one being 0.1 millimeter. as the diameter of the nylon fiber gets smaller, it attenuates, absorbs less. So you see less. Eventually, conventional X-rays just give up at 0.1, 0.2 millimeter. You just don't see them anymore. Of course, even smaller features, you just don't see them. With diffraction-enhanced imaging, you see every single fiber clearly with the same clarity. So here is an example of low-dose diffraction-enhanced imaging with high-energy X-rays. So on the left, you see the Fisher digital mammography. That's most advanced mammography system. So it was performed at 18 keV, so that the tumor mass, the fibrils, they will absorb more X-rays and cast better shadow. So for this reason, the dose is 3 milligrams. So on the right, you see the DI image at 40 keV. So keep note, for breast tissue at 40 keV, the tissue is almost transparent. Basically, most of the X-rays just go through the breast and hit the detector. But the X-rays are banned by the breast. The analyzer convert the banding of the X-rays to use for image. So you compare those two images, you see the tumor mass clearly in both, but for the DI image, you see the fibrils extending into the surrounding tissue much, much clearly. You just see the extent of the fibrillar extension. So this is done at 0.02 milligrams, 150 times less dose. Why so much less dose? Because as you made the object transparent, X-ray just goes through without being absorbed. Then there is no dose, almost no dose. Here is an example illustrating another powerful feature of diffraction-enhanced imaging. This is a human foot. So usually for X-rays, you take an X-ray of a human foot and joint, you see the bone, that's it. You don't see the soft tissue, you don't see the tendons, you don't see the cartilage, which is what you're really looking for. You take an MRI, you don't see the bones, you see only the soft tissue. With DEI, because it's optimized for soft tissue, but it also uses X-rays attenuation that image the bone. You really see the bone, the tendons, the soft tissue, and more importantly, you see the interface in between them. That's where most disease actually happen. So this is very powerful. So DEI can also contribute to Alzheimer's disease research. So you see on the left side is a dissected mouse brain which has Alzheimer's plaques in it. So of course it's dissected and you take a picture, photograph. You see clearly the plaques. On the bottom is zooming of the square region. So on the right-hand side, you see DEI image. So this way it's a CT, so you don't need to cut up the sample. You can actually see what's happening inside the mouse brain. You do see those small plaques. They are about 50 to 100 micron in diameter. And they're soft tissue. They're very, very low contrast. Without DEI, there's no way you can see them with X-rays. So with DEI, you actually do see them. So we didn't just stop at synchrotron because I love synchrotron all my life. I do experiment with synchrotrons. So the radiologists, they loved our pictures. But then they say, hey, we can't afford to send millions of patients to a synchrotron. That's just will not work. So I'll tell them, well, the principle of just converting angle to intensity is the same, regardless if you have a synchrotron on an X-ray tube as a source. So to prove me right, to prove them wrong, there are lots of people who are suspicious. We actually shut down the synchrotron, and over a few months, we went out and bought an X-ray tube from GE. We installed it in the hatch. So instead of using synchrotron X-rays as source, we are just using this good old X-ray tube as the source. And then we can do the same DEI image with the same analyzer crystal. So here is the result. So on the left side, you see the GE digital image of a human breast. So 400 millirad dose. That was taken at 18 keV because they want to highlight the absorption, so they pay a penalty for those. For the DEI image, we imaged at 60 keV, so breast is almost transparent. The dose was only 8 millirad, much, much smaller. Still, the radiologists compare those two images. They see similar kind of features. So basically, we have proven without the synchrotron, with just a good old X-ray tube, you can still do DEI imaging. So that paves way for future commercialization of this technique. So in summary, the DEI uses X-ray refraction as a contrast mechanism. It does not rely on absorption of X-rays. So at 10 to 100 times less dose, DEI is suitable for diagnosing soft tissue diseases. So I run a beamline called HEX beamline. It's a brand new beamline at the NSLS-II. It provides high energy, high flux X-rays. So for these reasons, it's really ideal for DEI research for the future. So we already published 2 papers on how to implement DEI at this brand new beamline. So in the picture, you see my colleagues, they are posing in front of this brand new beamline. So I don't live in vacuum, so I'm helped by lots of people with different expertise. Dean Chapman from University of Saskatchewan, Bill Tomlinson from Canadian Light Source, Etta Pisano from Harvard Medical School, Jane Lee and Carol Newman from Rush Medical College, Dean Connor from Medical University of South Carolina, and Chris Parham from UC San Francisco, and Norman Hashner from Qatar University. Of course, locally, Andy Broadbent, Mike Jacopoulos, Mike Lucas, Neil Vo, and many others contribute greatly to this effort. Of course, there are many, many others that I will fail to mention. Thank you.